Nigeria continues to face significant challenges in addressing pediatric HIV and AIDS, mother-to-child transmission, and HIV and AIDS in general, according to reports. Latest statistics suggest that over 1.9 million people living with HIV and AIDS in Nigeria, 72,000 infections annually, and 53,000 related deaths. Nigeria still faces 34% of pregnant women living with HIV under the treatment coverage. The numbers are high and the work is being done. I am Aisha, Salihu, and today on Healthy Living, we are focusing specifically in the context of HIV and AIDS. We'll delve into the care of HIV and AIDS in children, the prevention of mother-to-child transmission, and the significant strides made by the National Agency for the Control of AIDS in the fight against this epidemic. Joining us is the Deputy Director and Head of the Policy and Advocacy Division at NACA, who is also a pediatrician, Dr. Miriam Ezekwek. Thank you so much for joining us, Dr. Miriam.
Thank you. Glad to be here.
Our discussion today will shine a light on the challenges and achievements in addressing HIV and AIDS in children and mothers and explore the future projections for eliminating the epidemic. We'll also discuss the innovative strategies that NACA is employing to achieve these goals. Now, Doctor, HIV and AIDS remains a significant public health challenge in Nigeria, with children being among the most vulnerable groups affected by this epidemic. I'd like to hear from you. As a pediatrician, what are some of the unique challenges in managing this HIV and AIDS in children, compared to adults?
Thank you very much, Aisha, for that question. Children are especially more vulnerable to HIV and AIDS infection. And this starts from the fact of who they are as children and the fact that they are not able to have too much of a say when it comes to mother-to-child transmission. Antiretroviral drugs and the PMTCT program is given to pregnant women to ensure that during the stages of pregnancy, delivery, that's childbirth, as well as breastfeeding, we can reduce and bring to zero, actually, the transmission of mother-to-child of HIV. Children are particularly more vulnerable because they, as you know, they are not earning, they're under the care of their parents. So whatever situation the parents have in terms of vulnerability, normally we say this word a lot, and this has to do with the health status of the parents, living condition of the parents, economic well-being, capacity, actually, amount of skills that the parents have. Children have a way of inheriting this if the children are not properly targeted. So that's one level that makes children more vulnerable. Another is even in the drugs itself. Adults have up to 8 classes of medication or antiretroviral drugs that they can take. But for children, because of safety, we normally limit it to just 3 classes of drugs, which are usually for short. I don't think I need to say all the technical terms, but just know that there are 3 classes. That's the nucleoside reverse transcriptase inhibitors, the non-nucleoside transcriptase inhibitors, and then the protease inhibitors. So these affect the HIV virus at different levels. Then another problem that children have that makes them more vulnerable is them even understanding what they are really suffering from. Some children, growing up, they will have issues of swallowing drugs. Even children who are not HIV positive have challenges in swallowing drugs, even eating, and having to feel differently from their mates. So parents have to be adequately empowered to understand how to ensure at an age where the children don't even have the understanding yet that they should take their drugs in the right amount, at the right time, every day. Then children sometimes have to visit family and visit friends. So you go to into those situations, and the children around or even the other adults around may start to wonder that why are you taking this medication? So that takes me to the level of disclosure. Parents have to be empowered to know who to disclose the HIV status of their children to help them to grow. And in particular, those that are really, really important is the healthcare provider to that child. It could be nurses, it could be the persons in the hospital, and then children who have to undergo regular tests, you know. They have to also have their regular immunizations. And these regular immunizations, children who are HIV positive have to be managed by a HIV specialist most of the time, assuming their pediatrician doesn't have all the skills, because it's related to the level of the CD4 in the child, because there's some immunizations that are live immunizations. So you cannot give, for example, if you don't know the level, it's not all the drugs on our national immunization schedule that a HIV positive child can take at the same time. But that does not mean that immunizations are not important and necessary for them, but they have to be managed a little bit more differently from persons or children who are not HIV positive.
I was actually going to come to the compatibility of the drugs when you talked about immunization and vaccination. And now I hear you about the challenges you have stated regarding the care for children living with HIV and AIDS. Now, let us come to the expected health outcomes of those children. You did talk about how adults are expected to take about 8 categories of drugs or management care, but for children, you said it's just 3. So let's say for a child who has been consistent with using this 3 drugs, I'd like to hear from you. What are the expected health outcomes for children who are very religious with using this kind of medication?
Okay, thank you. When children use their medications adequately and correctly, they will have the same health outcomes as children who are not HIV positive, as long as you satisfy conditions that enable children to thrive. By this I mean adequate nutrition, which is very, very important, because growing children need certain classes of foods to take, and it's much more important with children who are HIV positive. Then they also require special care, because they are prone to what we call opportunistic infections. These are infections that occur when a person's immunity is low. And, you know, you have those in the tuberculosis category. You could have diarrheal illnesses. These are illnesses that also affect other children. But for a child with HIV that is HIV positive, you need to be especially careful, which is why at a very early age, children who are HIV positive should be taught how to do hand washing, continuous hand washing. They should be taught how not to pick things from the ground and put in the mouth. Hygiene in general is very, very important. Then you also need to encourage them to play, actually, because playing is one of the things that enable children's bones and joints to develop properly. Then they also need to be told how to, or taught how to do some quick emergency like first aid, because if a child is HIV positive, maybe he runs and scratches himself and he has a wound, he should know how to use a bandage to quickly bandage his wound, so that, because you know, when we talk about HIV, it's very, very important for us to know that the virus is, though it's a serious illness, but the transmission in terms of maybe blood spills, maybe through saliva and other such communications that people may have, it's not so high like certain other viruses. Maybe take, for example, hepatitis. So children very, very early need to be taught how to take care of little you know, incidences that require first aid. Thank you.
Earlier, Doctor, you talked about how the challenges we're facing with managing HIV and AIDS care in children largely depends on the parents. Now, this brings me to my next line of question. How accessible are pediatric HIV treatments in Nigeria, especially in rural or underserved areas?
Well, you're now talking about our human resources for health generally.
Right.
We all know, because there are certain ratios that are needed, the doctor to individual ratio for any country. Data shows that we're not doing very great on that, and you now find that having a specialist, because to be a pediatrician means you go through the normal medical school, then you go back, do your residency program, and then you now take some more time again to specialize in a sub area, because patients, doctors, pediatric doctors that take care of HIV issues are normally infectious disease specialists. So that takes some more time to specialize in. So you find that we don't have enough of them, even in the urban areas, not to talk of the rural areas. So what we've come to do now, we've done a lot of decentralization. We have the National HIV Treatment Guidelines, and we use these guidelines to train health workers in general on what to do, because there are some places, because HIV care, if you are looking for a specialist, you may only find them in teaching hospitals, but you find that for pediatric HIV care, it's been decentralized down to the secondary health facilities such as general hospitals, and then to primary health care facilities too, whereby you may have the health officer in charge. So at each level, they are trained using these guidelines to know what to do and how. And in fact, majority of children that live with HIV may not require too much, looking for a HIV specialist, because the health sector has put in place certain strategies such as task shifting to enable other cadres of healthcare workers to give the needed services for HIV in children.
Okay, now, apart from the fact that we already know that we have a challenge with human resource for health, it's something that is very common in Nigeria these days. Now looking at HIV and AIDS, what about the specific drugs that you talked about? Are they readily available, affordable and accessible in these healthcare centers that you have stated?
Okay, thank you very much. I'm glad to let all Nigerians know that the HIV drugs are readily accessible in Nigeria. In fact, there's the first drug that is given to the baby within 72 hours, that is nevirapine. That's available even at primary health care level. Then there's the one that they will now take for the next 6 weeks, which is the zidovudine. It's also available. For quite some time now, we've not had stockouts. So these drugs are available everywhere, and it's made possible due to partnerships. We have a lot of international funders in the country, together with donors and even national and local donors, and the Nigerian government, who pull all their resources together and do a joint procurement of these drugs, and also do logistics to ensure that these drugs are delivered to the last point using what we call the last mile logistics. So we can say that we don't have issue of stockouts, and NACA has done a lot of work over the years to actually make our systems more robust.
Okay, now speaking about NACA, you have stated quite a number of initiatives, but I'd like to hear from you. Are there any specific programs or other initiatives by the same NACA aimed at improving the quality of life for children living with HIV and AIDS?
Okay, thank you. As you know, one of our key mandates as NACA is to ensure there's a multi-sectoral coordination of the HIV response in the country. So what that means is that it's our job to ensure that whoever does something best, whatever organization does an actual activity best, is now supported to deliver as efficiently as possible. So what it means that we've been working with the Federal Ministry of Health and Social Welfare, the ministries at state levels, other line ministries, Women Affairs, Youths. We're all partners and we all sit together. even the National Primary Healthcare Development Agency. And good thing now that NACA now sits under the supervision of the Federal Ministry of Health and Social Welfare, which makes it much easier for coordination. So in essence, what we've done is to expand access to pediatric HIV care. We've also been able to encourage the production, local production of active pharmaceutical ingredients. These are the main agents that are used in producing HIV drugs in country, and a lot of work has gone in that direction. So we've been doing a lot of advocacy. We've been doing a lot of not just advocacy on production of antiretroviral products or commodities. We've also done that in ensuring sustainability. Sustainability means ensuring that when the funding, which I would like to say that it's really more or less more internationally based, because our drugs are free. HIV drugs or medication in every government designated facility is free in the country, if you go from the north to the south to the east and to the west. So nobody needs to pay for that. Then we also have the test kits. These are also free in all government designated facilities. In particular, pediatrics requires that children who are born to HIV positive mothers, they will need to take a test at least 3 times before they are 18 months old, and that is to check at 2 months, then at birth, at 2 months or 14 weeks, and then at 18 months. So when these dry blood spots are taken, they are also tested for free. They don't pay. So the government has really done a lot with the partners. So at the end of the 18 months period, if a woman has gone through PMTCT program successfully, that baby would be definitely HIV negative. Then we've also used what we call advocacy champions. And there's nothing as strong as a mother who is HIV positive, who has a HIV negative child, advocating strongly, as well as community actors and faith-based organizations. So these are all our partners to ensure that the HIV, especially in children, that we bring it down to a very, very minimal level.
Okay, thank you so much, Dr. Miriam. Now, we have, let us move away from the HIV and AIDS care in children and move very quickly to the second segment, which is the prevention of mother-to-child transmission. Now, I'd like to hear from you. Can you walk us through the process of preventing mother-to-child transmission of HIV?
Okay, thank you. The first thing first is primary prevention.
Okay.
Primary prevention means that a human being, whether you're male or female, should not have HIV. And that means empowering you to make the right choices. So we look at the adolescents and young people as the first place to start. That is persons between the age of 10 to 24 years. And we have a lot of programs, which is mostly on communication, awareness creation, so that they don't make wrong choices. And this is simplified into a strategy for them, which is the ABCD. A for abstinence, especially when you're young, you don't have any, you're not married, you don't have a partner. And then B is when you're married or you have a partner, you be faithful to that partner.
Okay.
And then C is assuming maybe along the line you may want to use the condom. And then the D is now do not be unfaithful, don't do drugs. Because why I mention drugs is that drugs tend to reduce people's awareness of risk.
Okay.
And drugs too, especially those that have to do with injectable drugs, enable persons to use sharps. And sharps are one of the ways of transmitting HIV from one person to the other. Now, so once somebody is able to have the empowerment and the tools to do that, you now become a full-fledged adult, and you would settle and then have, as a woman, the next stage is childbearing. Before a woman goes into childbearing, she should test herself and to know her status. If she's tested and she's HIV positive, then she begins to take antiretroviral medication for her own health, irrespective of her being a mother in the future. Now, if she's already taking ART for her own health, and the best way of knowing that you're taking it efficiently is your viral load. Your viral load level should come down so low so that it is undetectable. An undetectable viral load level means that it's untransmissible. So if a woman is taking antiretroviral drugs prior to being pregnant and she's taking it well and it's undetectable, then she can't transmit to her baby. Now, if at the point of antenatal care, which is one of the parts that we use in ensuring that PMTCT works very well, the PMTCT wants every pregnant woman to start antenatal care in the first trimester of pregnancy. So if the lady or the woman is tested and she's positive, then PMTCT starts. Certain drugs are now given to her. She starts to take it because the aim is that at the point of delivery, she should have been able to achieve undetectable viral load levels. Then, and if that is the case, she can even deliver her baby normally. That is through the vaginal route.
Okay.
Now, if the viral counts are still high, or maybe her CD4 count is not what we want it to be, then she may have to go through an alternative route like a CS. But if a woman goes through PMTCT adequately, she can deliver normally, she can breastfeed her baby normally, so that she avoids the stigma. Because in our environment, it's expected that every woman will breastfeed. So if a woman is carrying a baby and she's not breastfeeding and she says, my baby, people start to wonder that, did you actually birth the child? But of course, if a baby is yours, no matter the route, it's your baby. Whether you adopt, it's your baby. Okay. So, if the baby is now born, the baby now goes through the earlier mentioned tests, while the woman that is HIV positive doesn't stop taking her medication, because like I mentioned, she will now be on antiretroviral drugs for life because she also needs it. We know that HIV for now is not yet it's not yet curable, but you can take medication that will allow you to live as long as any other person. Okay. So that is the path. And then, of course, she now continues like any other person, attending her clinic and having her medication as and when due.
Okay, doctor, you have stated quite a number of management techniques and measures, but then I'd like to know, what then would you say are the key barriers to achieving 100% prevention of mother-to-child transmission, especially in Nigeria? I mean, the figures are high.
Well, I would say that in fact, not I would say, but data shows that the key barrier is stigma and discrimination.
Okay.
Stigma and discrimination, because we are still living in a space where some people think that you contracted HIV due to some quote and unquote immoral behaviors or some judgments on the person, not knowing that it may not be so. So stigma and discrimination is the last obstacle that we need to overcome to ensure that we have a HIV-free generation in Nigeria. And particularly for women, you think about it, look at the social construct of gender, the way women are in society. So you have situations, which I have even experienced some, where a woman may be HIV positive in a marriage and may not be able to go freely to the health facility to get her medication because she needs a male member of the family to give permission. So, and some families will think that allowing people to know you're going to go and take HIV medication will be a stigma to the family. So we are working with lots of partners, the community gatekeepers, the faith-based organizations, because people listen to them a lot. So we need to work more closely, but we've been working with them. And then even the networks of people living with HIV, our partners. We have associations for youths, associations for women, and associations for the main body. So we're all working together to ensure that HIV, stigma and discrimination comes to a halt.
Okay, Doctor, just on a final note, just, to round up the program, I'd like to hear from you. What role would you advise that the general public and stakeholders play in ensuring the elimination of HIV and AIDS as a public health threat in Nigeria, by 2030?
Okay, thank you. I would say that first, for the general public, HIV in the workspace. We have laws in the country now. The anti-discrimination law that was passed in 2014. So if anyone is being discriminated against and please know that, inform that person that the person can take it up legally. Because there are some workspaces where when an employee comes in, the test is carried out without the permission of the new worker or the new employee. Then another thing is for us to know that we have a toll-free line, 6222, which you can call. Toll-free means that you don't need to pay. Where more information can be given to you. That's in the workspace, in the general population. Then for the general population too, I would like to say that HIV cannot be shared by holding hands, cannot be shared by living in the same space with somebody. But what the person that is living with HIV wants from the general public is empathy and to know that they are not different from any other person. Okay,
that's about it. Thank you so much. We have been speaking with Dr. Miriam Ezekwe, who is the Deputy Director and Head of the Policy and Advocacy Division at NACA, and she's also a pediatrician. Thank you so much for your contribution on the program at this moment.
Thank you very much.
And that concludes this week's episode of the program, Healthy Living on Trust TV. For more of this particular program, you would like to, drop comments, contributions, and suggestions, do well to follow and subscribe to all Trust TV social media handles and download the Trust TV app on iOS and Android devices across their respective stores and get live updates on the YouTube live stream and the website. I am Aisha. Salihu, thank you so much for your time, but we will be leaving you with some facts you need to know on HIV and AIDS.